Pathology for Physical Therapy Assistant, Chapter 4, The Immune System, Part 4, page 100. Hypersensitivity disorders. An exaggerated or inappropriate immune response may lead to various hypersensitivity disorders. Such disorders are classified as type 1, 2, 3, or 4, although some overlap exist. Table 4.2. Overreaction to a substance or hypersensitivity is often referred to as an allergic response. Although the term allergy is widely used, the term hypersensitivity is more appropriate. Hypersensitivity designates an increased immune response to the presence of an antigen, referred to as an allergen, that results in tissue destruction. The damage and suffering come predominantly from the immune response itself rather than from the substances that provoke it. The several types of hypersensitivity reactions include immediate, late phase, and delayed, based on the rapidity of the human response. Immediate hypersensitive reaction usually occurs within minutes to exposure to an allergen. If the skin is affected, blood vessels dilate, and fluid accumulates, causing redness and swelling. In the eyes and nose, increased fluid and mucus secretions cause tearings and a runny nose. Late phase inflammation and symptoms persist for hours to days after the allergen has been removed and can cause cumulative damage, progressive lung disease, if they persist. Delayed hypersensitivity reaction occurs after sensitization to certain drugs or chemicals, penicillin, poison ivy. These reactions often take several days to cause. Type 1 hypersensitivity. Immediate hypersensitivity, allergic disorders, anaphylaxis. Type 1 hypersensitivity reactions include hay fever, allergic rhinitis, urticaria, extrinsic asthma, and anaphylactic shock. Allergens are a special class of antigens that cause an allergic response. These normal harmless substances are inhaled: mold, spores, animal dander, dust mites, grasses, weeds, eaten, nuts, fruits, shellfish, eggs, or injected venom from fire ants, wasps, bees, hornets, or they can come in contact with the skin or mucous membranes, plants, cosmetics, metals, drugs, dyes, latex. Immunoglobulin E, IgE, one of the 5 types of antibodies produced in the response to specific antigens, reside on mast cells in connective tissues, especially the upper respiratory tract, GI tract, and dermis. When IgE meets the pathogen again, an immediate response occurs with histamine release along with other inflammatory medicators. Chemotactic factors, prostaglandins, and leukotrienes that enhance and prolong the response initiated by histamine. If this response becomes systemic, widespread release of histamine rather than just local tissue response results in systemic vasodilation, bronchospasm, increased mucus secretions, and edema, referred to as anaphylaxis. Classic associated signs and symptoms are wheezing, hypotension, swelling, urticaria, and rhinorrhea. Clear, runny nose, often accompanied by sneezing, figure 4.9. Anaphylaxis is life-threatening emergency and requires immediate intervention with injected epinephrine to restore blood pressure, strengthen the heartbeat, and open the airways. Bee stings remain the number 1 cause of anaphylaxis. Other triggers include penicillin, foods, animal dander, children, semen, and latex. Type 2 hypersensitivity, cytotoxic reactions to self-antigens, when the body's own tissue is recognized as foreign or non-self, the cellular membrane of normal tissue is disrupted and ultimately destroyed. Self-antigen disorders include blood transfusion reactions, hemolytic disease of the newborn, autoimmune hemolytic anemia, and myasthenia gravis. Type 3 hypersensitivity, immune complex disease, when circulating immune complexes, antigen-antibody complexes, successfully deposit in tissues around small blood vessels, they cause acute inflammation and local tissue injury. The subsequent vasculitis most commonly affects the skin, causing urticaria, wheals, joints causing synovitis, such as in rheumatoid arthritis, kidneys causing nephritis, pleura causing pleuritis, and pericardium causing pericarditis. Systemic lupus erythematosus, CLE, is a classic picture of vasculitis occurring in various organ systems. The antigen is the individual's own nucleus of cells. Anti-nuclear antibodies, ANAs, are made, which in turn form a complex with the antigen and are deposited in skin, joints, kidneys, causing acute immune injury. Type 4 hypersensitivity, cell-mediated immunity. Type 4 is a delayed hypersensitivity response, such as the reaction that occurs in contact dermatitis after sensitization to an allergen, commonly a cosmetic adverse, topical mediation, or plant toxins such as poison ivy. Latex sensitivity or the response to a TB skin test present 48 to 72 hours after the test. Special implications for the PTA, hypersensitivity disorders. Type 4 reactions may occur in response to lanolin added to lotions, ultrasound gels, or other preparation used in massage or tissue mobilization, necessitating careful observation of all people for delayed skin reactions to any of these substances. When the first exposure, no reaction necessarily occurs, but antigens are formed, and on subsequent exposure, hypersensitivity reactions are triggered. Anyone with known hypersensitivity should have a small area of skin tested before use of large amounts of topical agents in their therapy setting. Careful observation throughout treatment is recommended. Beginning in the 1980s, the use of latex gloves to protect healthcare workers against exposure to blood and bodily fluids increased. Since then, the number of reported cases of latex sensitivity has also increased. Reactions to latex range from contact dermatitis, type 4 hypersensitivity, to anaphylactic shock, type 1 hypersensitivity. PTAs who are allergic to latex should avoid contact with latex gloves and other products that contain latex. Use of low powder-free and non-latex gloves provide PTAs with a strategy for preventing exposure to latex allergens. Autoimmune diseases. Definition and overview. Autoimmune diseases fall into a category of conditions in which the cause involves immune mechanisms directed against self-antigens. More specifically, the body fails to distinguish self from non-self, causing the immune system to direct immune responses against normal self-tissue and become self-destructive. More than 56 autoimmune diseases have been identified, affecting everyone from skin and joints to vital organs. Autoimmune diseases can be viewed as a spectrum of disorders, some of which are systemic and others of which involve a single organ. Some of the known diseases most likely to be seen in the rehabilitation setting are listed in Table 4.3. At one end of the continuum, in organ-specific diseases, in which localized tissue damage occurs that result from the presence of a specific autoantibodies, in the middle of the continuum are disorders in which the lesions tend to be localized in one organ, but the antibodies are not organ-specific. An example is primary biliary cirrhosis, in which inflammatory cells infiltration of the small bile ductules occurs, but the serum antibodies are not specific to the liver cells. At the other end of the spectrum are non-organ specific diseases in which lesions and antibodies are widespread throughout the body and not limited to one target organ. Etiologic and risk factors. Although the autoimmune disorders are regarded as acquired diseases, their causes often cannot be determined. Autoimmunity is believed to result from a combination of factors including genetic, hormonal, women who are affected more often than men by autoimmune diseases, and environmental influences, exposures to chemicals, other toxins, or sunlight and drugs that may destroy suppressor T cells. Although no single gene has been identified as being responsible for autoimmune disease, clusters of genes seem to increase susceptibility. The influence of hormonal factors is confusing because some autoimmune disease occur among women in their 20s, 30s, when estrogen is high, and others develop after menopause or before puberty, when estrogen levels are low. During pregnancy, many women with rheumatoid arthritis or MS experience complete remission, whereas pregnant women with SLE often experience exacerbations. Other factors implicated in the development of immunologic abnormalities resulting in autoimmune disorders include viruses, stress, cross-reactive antibodies, and various autoimmune diseases occurring in women who have had silicone gel breast implants. This organ-specific autoimmune diseases have been associated with musculoskeletal problems. Pathogenesis. Autoimmune disorders involve disruptions of immunoregulatory mechanisms causing normal cell-mediated and humoral immune responses to turn self-destructive, resulting in tissue damage. The exact pathologic mechanism for this process remain unknown. It has been shown that the innate immune system has an important role in determining whether T cells become activated and functional in autoimmune disorders. Researchers suspect that more than one part of the immune system must be involved for autoimmune disease to develop. Some autoimmune diseases affect a single organ, pancreas and type 1 diabetes, whereas others affect a large system or more than one system, MS. In some cases, the autoimmune process overstimulates organ function, as in Graves' disease, in which excess thyroid hormone is produced. Many autoimmune diseases are associated with characteristics autoantibodies. In other words, the body begins to manufacture antibodies directed against the body's own cellular components or specific organs. These antibodies are known as autoantibodies in the case producing autoimmune diseases. Antibodies specific to hormone receptors on the surface cells have been found and determined to be partially responsible for some conditions. Examples include myasthenia gravis, in which anti-acetylcholine receptor antibodies are involved. Graves' disease, in which antibodies against components of thyroid cell membranes, including the receptors for thyroid-stimulating hormone, are responsible. In certain cases of insulin-resistant diabetes mellitus, in which the antibodies affect the insulin receptors on cells. Other diseases involving autoimmune mechanisms include rheumatic fever, rheumatoid arthritis, autoimmune hemolytic anemia, idiopathic thrombocytopenic purpura, and post-viral encephalomyelitis. Clinical manifestations. Autoimmune disorders share certain clinical features and differentiate differentiation among them is often difficult because of this. Common findings include synovitis, pleuritis, myocarditis, endocarditis, pericarditis, peritonitis, vasculitis, myositis, skin rash, alterations of connective tissue, nephritis, constitutional symptoms such as fatigue, malaise, anyways, are also common. Medical management. Okay. Diagnosis can be difficult because autoimmune diseases are poorly understood, mimic one another, and often consist of vague symptoms such as lethargy or migratory joint pain. Laboratory tests may reveal thrombocytopenia, leukopenia, large excess or deficiencies. ANAs, rheumatoid factor, cryoglobulins, false positives, serologic test results, elevated muscle enzymes, and alterations in serum complement. Oh my goodness. Treatment of autoimmune diseases varies with specific disease. Treatments must maintain a delicate balance between adequate suppression of the autoimmune reaction to avoid continued damage to the body tissues and maintenance of sufficient functioning of the of the immune mechanisms to protect the person against foreign invaders. In general, autoimmune diseases are treated by the administration of corticosteroids to produce an anti-inflammatory effect. And salicylates, I don't know, whatever, to provide symptomatic relief. The wealth of new information gleaned from research in the last decade has been used to improve immunization strategies and hopefully will lead to new approaches to the reduction of immune tolerance. The development of an effective vaccine is under close scrutiny, as in the use of intense immunosuppression, immunoablation, followed by stem cell transplantation for the treatment of autoimmune disease. Because autoimmune disease is the result of genetic dysregulation, gene therapy may become a viable alternative in the future. Scientists have been involved in developing new drugs aimed at the mechanisms of autoimmunity rather than treating the effects. Systemic lupus erythematosus. Definition and overview. Lupus erythematosus, sometimes referred to as lupus, is a chronic inflammatory autoimmune disorder that appears in several forms, including discoid lupus erythematosus, DLE, which affects only the skin, usually face, neck, and scalp, and systemic lupus erythematosus, which can affect any organ or system of the body. The clinical picture of SLE reflects a continuum with different combinations of organ system involvement. The most common of these presentations are latent lupus, drug-induced lupus, antiphospholipid antibody syndrome, and late-stage lupus. Latent lupus describes a constellation of features suggestive of SLE, but does not qualify as classic SLE. Many people with latent lupus persist with the clinical presentation of signs and symptoms over many years without ever developing classic SLE. Drug-induced lupus may be diagnosed in people without prior history suggestive of SLE, in whom the clinical and serologic manifestations of SLE develop while the person is taking a drug. The symptoms cease when the drug is stopped, with the gradual resolution of serologic abnormalities. Late-stage lupus is defined as chronic disease duration greater than 5 years. In such cases, morbidity and mortality are from the disease itself or as a consequence of its therapy. These late complications may include end-stage renal failure, erythrosclerosis, pulmonary emboli, and avascular necrosis in late-stage lupus. When no evidence of active disease exists and the client is on low dose or no corticosteroids, cognitive disabilities are common manifestation. Incidence. SLE is primarily a disease of young women. It is rarely found in older people. It usually develops in young women of childbearing years, but many men and children also develop lupus. Lupus is 3 times more common in African American women than in Caucasian women, and is also more common in women of Hispanic, Asian, and Native American descent. SLE also appears in the first degree relatives of individuals with lupus more often than it does in general population, which indicates a strong hereditary component. However, most cases of SLE occur sporadically, indicating that both genetic and environmental factors play a role in the development of the diseases. Etiologic factors. The cause of SLE remains unknown, but evidence points interrelated immunologic, environmental, hormonal, and genetic factors. Immune dysregulation in the form of autoimmunity is thought to be the prime causative mechanism. SLE shows a strong familial link with a much higher frequency. Excuse me. This book is rough. With a much higher frequency among first-degree relatives. Evidence for genetic susceptibility is present, and linkage study in conjunction with genome scans may delineate this more specifically in the future. What do you say? As the human genome becomes more extensively mapped, a susceptibility gene may be found, although it remains possible that the differences in the disease, of course among ethnic groups, relate to the differences. Oh, see, look, I'm reading the same damn thing. Solely to their environment and other social factors. Other factors predisposing to SLE may include physical or mental stress, which can provoke neuroendocrine changes affecting immune cell function, streptococcal or viral infection, exposure to sunlight or ultraviolet light, which can cause inflammation and tissue damage, immunization, pregnancy, and abnormal estrogen metabolism. A higher incidence of SLE exacerbation occurs among women taking even low-dose estrogen contraceptives. Because an increased risk of thrombosis is possible in young women with SLE, estrogen-containing contraceptives are avoided or used at lower effective dose. The role of Epstein-Barr virus as a possible risk factor for the SLE remains under investigation. SLE may also be triggered or aggravated by treatment with certain drugs, which could modify both cellular responsiveness and immunogenicity of self-antigen. All right, pathogenesis. The central immunologic disturbance in SLE is autoantibody production. The body produces antibodies against its own cells. Deposition of the formed antigen antibody complexes at various tissue sites can suppress the body's normal immunity and damage tissue. In fact, one significant feature of SLE is that the ability to produce antibodies against many different tissue components such as red blood cells, RBCs, neutrophils, platelets, lymphocytes, or almost any organ or tissue in the body. This wide range of antigenic targets has resulted in SLE being classified as a disease of generalized autoimmunity. Given the clinical diversity of SLE, the disease may be mediated by more than one autoantibody system and several immunopathogenic mechanisms. Skin lesions demonstrate inflammation and degeneration at the dermal-epidermal junction, with the basal layer being the primary site of injury. Other organ systems affected by SLE are usually studied only at autopsy. Although these tissues may show nonspecific inflammation or vessel abnormalities, pathologic findings are sometimes minimal, suggesting a mechanism other than inflammation as the cause of organ damage or dysfunction. Clinical manifestations. Generally, SLE is more severe than discoid lupus, and no two people with SLE will have identical symptoms. For some people, only the skin and joints will be involved. For others, joints, lungs, kidneys, blood, or other organs and or tissues may be affected. Musculoskeletal system, arthroglias and arthritis constitutes the most common presenting manifestation of SLE, but the onset of SLE may be acute or insidious and may produce no characteristics clinical pattern other than early symptoms may include fever, weight loss, malaise, and fatigue. Acute arthritis can involve any joint, but typically affects the small joints of the hands, wrists, and knees. It may be migratory or chronic. Most cases are symmetric, but asymmetric polyarthritis is not uncommon. Unlike rheumatoid arthritis, the arthritis of SLE is not unusually erosive or destructive of bone, and symptoms are not usually severe enough to cause joint deformities, but pain can cause temporary functional impairment when deformities do occur. Ulnar deviation, swan neck deformity, or fixed supplication of the fingers often occur as well. Tendinosyvitis and tendon ruptures may occur. Cutaneous and membranous lesions. The skin rash occurs most commonly in areas exposed to sunlight, ultraviolet rays, and may be exacerbated by the use of cosmetic products containing alpha hydroxy acids. The classic butterfly rash over the nose and cheeks is common. Figure 4.10. Page 104. Discoid lesions associated with DLE are raised, red, scaling plaques with follicular plugging and central atrophy. This raised edging and sunken center gives them a cone-like appearance. Vasculitis, inflammation of cutaneous blood vessels, involving small and medium-sized vessels, may cause other skin lesions, including infarctive lesions of the digits, figure 4.11. Splinter hemorrhages, necrotic leg ulcers, or digital gangrene. Raynaud's phenomenon occurs in about 20% of people. Diffusion or patchy alopecia hair loss may be temporarily, with hair regrowth occurring once the disease is under control. Other permanent hair loss can occur from Where's that? However, permanent hair loss can occur from the extensive scarring of discoid lesions. Painless ulcers of the mucous membrane are common and involve the mouth, vagina, and the nasal septum. Cardiopulmonary system. Signs of cardiopulmonary abnormalities may develop, such as pleuritis, pericarditis, and dyspnea. Myocarditis, endocarditis, tachycarditis, and pneumonitis, acute or chronic, may also occur. Pulmonary hypertension and cognitive heart failure are less common and usually secondary to a combination of factors. Central nervous system. A significant number of people with SLE will have a CNS involvement at some point in their lives. oh, I'm sorry, at some point in their illness, sometimes referred to as neuropsychiatric manifestations. Clinical manifestations may be related to specific autoimmune bodies that react with nervous system antigens and or cytokine mediated brain inflammation and induced headaches, irritabilities, and depression most commonly. Emotional instability, psychosis, seizures, cerebral vasculature accidents, cranial neuropathy, peripheral neuropathy, and organ brain syndrome can also occur. Return to the previous level of the intellectual functions may follow remission of the neuropsychiatric flare, or permanent cognitive impairment may occur. The pattern of cognitive dysfunction is diverse. Intensity can vary within the same person and can be affected by mood. The person may have difficulties with verbal memory, attention, language skills, verbal fluency, verbal fluency. I just need to get done with this chapter. Verbal fluency, productivity, and psychomotor speed. Progressive cognitive impairment, even in the absence of clinically diagnosed episodes of the neuropsychiatric disease, people with SLE may or may not have other signs of lupus when they experience neurologic symptoms. Renal system. Pathologic changes may also occur in kidneys, where the glomerulus is the usual site of destruction, or other renal effects may include hematuria or proteinuria, progressing to kidney failure. Other symptoms: anemia from decreased erythrocytes is common finding with associated amenorrhea, cessation of menstrual blood in women, sometimes after the spleen. What am I saying? Sometimes the spleen and cervical, axillary, and inguinal nodes are enlarged. Hepatitis may also develop. Nausea, vomiting, diarrhea, and abdominal pain may occur with GI involvement. All symptoms mentioned in this section can occur at the onset or any time during the course of lupus. Nearly all people with SLE experience fluctuations in disease activity with exacerbation and remission. Okay. 4.6. Special implications for the PTA. Systemic lupus erythematosus. As in fibromyalgia, physical and occupational therapy intervention can be important components of the overall treatment plan. Recurrence of disease can be managed with careful control and sometimes restrictive activities. After an exacerbation, gradual resumption of activities must be balanced by a maximum rest periods, usually 8 to 10 hours of sleep at night and several rest periods during the day. Most of the principles and reference material outlined in the section on fibromyalgia also applies to SLE. Management of joint involvement follows protocols for rheumatoid arthritis. Clients with skin lesions should be examined thoroughly at each visit by the physical therapist. The PTA can be instrumental in teaching and assisting therapists. The PTA can be instrumental in teaching and assisting with skin and prevention of skin breakdown. Functional limitations among people with SLE vary according to the type of degree of the disease. Generalized fatigue, defined as the inclination to rest, even though pain and weakness are not limiting factors, is a common problem and can be very debilitating, especially for those individuals with both SLE and fibromyalgia, or just people who read this damn book. Okay, the PTA can instruct clients how to pace activities and conserve energy. Follow a prescriptive exercise plan. Avoid excessive bed rest and protect joints. Excessive bed rest can worsen fatigue, promote muscle disuse and atrophy, and promote osteoporosis. Prescriptive exercise should strengthen the muscles and improve endurance while avoiding undue stress on inflamed joints. Septic arthritis or necrosis may develop as a complication of SLE or its treatment. Septic arthritis is common in SLE, but should be suspected when one joint is inflamed out of proportion to the others. People with SLE may develop drug-related myopathy secondary to corticosteroids or as complications of anti-malarials. Anyone taking corticosteroids or immunosuppressants must be monitored carefully for signs of infection, especially people at heightened risk of infection, such as those with renal failure, cardiac, valvular abnormalities, or ulcerative skin lesions. The client should contact the physician if a fever or any other new symptoms develop. The PTA can provide osteoporosis prevention and intervention and management. High-dose oral corticosteroid treatment remains the major predisposing cause of avascular necrosis in SLE and other disorders. The most common site is the femoral head of the hip. Less commonly, the femoral condyle of the knee is affected, although the condition may be bilaterally, it most often manifests as an insidious onset of unilateral hip or knee pain that is worse with ambulating but often present at rest. Symptoms are progressive over weeks to months. Observe carefully for any signs of renal involvement such as weight gain, edema, or hypertension. Take seizure precautions if there are signs of neurologic involvement. The PTA may recognize signs of cognitive dysfunction or decline, either directly observed in the client, or by family report. These manifestations should be reported to the physician for consideration in evaluating medications. If Raynaud's phenomenon is present, teach the client to warm and protect hands and feet. Okay. Oops, I'm trying to figure out how to pause this. Phone is locked. Okay. All right, push through. All right. Fibromyalgia. Definition and overview. Fibromyalgia or fibromyalgia syndrome, FMS, is a chronic muscle pain syndrome. It is considered a syndrome and not a disease, and now has been defined by the American College of Rheumatology, ACR, as a pain that is widespread in at least 11 or 18 tender points. FMS currently falls under the auspices of rheumatology, having originally been determined to have no known organic basis. However, with the recent advances in understanding of FMS with documented objective biochemical, endocrine, and physiologic abnormalities, it may be characterized as a biologic organic disorder associated with neurohormonal dysfunction of the ANS. It is commonly associated with many other conditions, hypothyroidism, rheumatoid arthritis, connective tissue disease, SLE, CFS. The link between FMS and these disorders is under investigation. Fibromyalgia has been differentiated from the myofascial pain in that fibromyalgia is considered a systemic problem with widespread multiple tender points as one of the key symptoms. Myofascial pain is localized condition specific to a muscle and may involve as few as one or as many as several areas with characteristic trigger points that are painful and refer pain to other areas when pressure is applied. The person with FMS may have both tender points and trigger points, requiring specific treatment intervention for each. The person with myofascial pain syndrome does not exhibit other associated constitutional or systemic signs or symptoms unless palpation elicits a painful enough response to elicit an ANS response with nausea and or vomiting, increased blood pressure, and increased pulse. It has been proposed that fibromyalgia and CFS are two names of the same syndrome. With CFS being an early form of FMS, but as present SFS is thought to differ by the greater degree of fatigue. People with fibromyalgia tend to experience more pain in contrast to CFS. Fibromyalgia is associated with a variety of initiating or perpetuating factors such as psychological distressing events, primarily sleep disorders, inflammatory rheumatoid arthritis, and acute fibro illness. Fibromyalgia and CFS have similar disorders. Sleep physiology and evidence suggest a reciprocal relationship of the immune and sleep-wake symptoms. Interference with either system has effect on the other, and will be accompanied by the symptoms of CFS. A significant number of people with FMS meet the criteria for CFS and vice versa. Seriously, for anybody who's actually listening to this, which I'm surprised if you made it this far, go on YouTube and just look up these different diseases. Find a really nice animated one that's super simplified, because although I understand it better when I'm actually listening to myself, I really don't understand what the hell this author is talking about. All right, let's finish this up. Incidence. Fibromyalgia occurs in more than 6 million Americans. It has now surpassed rheumatoid arthritis as the most common musculoskeletal disorder in the United States. Women are affected more often than men. 90% are women, with symptoms appearing from age 20 to 55. Although it's been diagnosed in children as young as 6 and adults as old as 85 years of age. Risk factors. Risk factors or triggering events for the onset of fibromyalgia may include prolonged anxiety, emotional stress, trauma, rapid steroid withdrawal, hypothyroidism, and viral and non-viral infections. Fibromyalgia may also develop with no obvious precipitating events or illnesses. It is more prevalent in minimally to moderately physically fit persons and is not usually found in highly trained athletes. A strong correlation exists between fibromyalgia and anxiety or depression. It remains unclear whether these factors are contributory or a result of this condition. Etiologic factors. Research is now ongoing to determine the cause of fibromyalgia. Most likely, the initiation of this condition is multifactorial. Debate continues over whether fibromyalgia is even an organic disease, and if so, whether it is caused by abnormal biochemical, metabolic, or immunologic pathology. Possible etiologic theories include diet, viral organ sleep disorder, occupational, seasonal, or environmental influences, psychological distress, adverse childhood experiences, including sexual abuse, and a familial or hereditary link. Sorry, that was my computer. Pathogenesis, autonomic nervous system. The activity of the skeletal muscles, heart, stomach, intestines, blood vessels, and sweat glands during daily stress tends to be excessive in fibromyalgia. These organs overactive, resulting in the heart beating faster, the stomach secreting excessive digestive juices and contracting erratically, the smooth muscles of the intestines and bowel contracting abnormally, breathing becomes rapid and shallow, and blood vessels constricting, which decreases blood flow to body parts. These and other ANS responses may occur in response to relatively mild life stressors and linger even after cognitive memory of the event is gone. In FMS, the nervous system's ability to modulate and return to normal is fragile and lack the subtle ability to respond quickly. Responses are more exaggerated, and the return to normal takes more time. The enteric system, autonomic nervous control of the digestive system, is often significantly disrupted in fibromyalgia. Digestion is often compromised, and the absorption of nutrients in the bloodstream where they can be used by the body for cell function is often inadequate for healthy daily function. Page 106. Sleep disturbances may contribute to fibromyalgia symptoms. Researchers have investigated alterations of the neuroendocrine systems that accompany disordered sleep physiology, resulting in the neurorestorative sleep, pain, fatigue, and cognitive and mood symptoms that people with fibromyalgia and CFS experience. Immune system. Immune cells activated in response to infection, inflammation, or trauma release pro-inflammatory cytokines that signal the CNS to release glia within the brain and spinal cord. Pain has been classically viewed as being mediated solely by neurons, but the discovery that spinal glia, microglia, and astrocytes amplify pain has changed this view. When glia cells become activated by sensory signals arriving from the periphery, they can release a variety of substances known to be involved in chronic pain. Clinical manifestations. Fibromyalgia is characterized by muscle pain as the major symptom, often described as aching or burning, a migraine headache of the muscles. Diffuse pain or tender points are present on both sides of the body in many muscle groups, including the neck, back, arms, legs, jaw, feet, and hands. Figure point 12. Sleep disturbances result in fatigue and exhaustion even after a night's sleep. Men with fibromyalgia typically have fewer symptoms and milder tendon points, less hurt all over reports. Less fatigue and fewer incidents of irritable bowel syndrome compared with women who have FMS. Other symptoms or associated problems occur with high frequency, table 4.4, sometimes more incapacitating than the pain and tender points. Symptoms are often exacerbated by stress, overloading physical activity, including overstretching, damp or chilly weather, heat exposure or humidity, sudden change in barometric pressure, trauma, or another illness. People with fibromyalgia who are aerobically fit manifest fewer symptoms than those who remain physically deconditioned and aerobically unfit. Biofeedback specialists have shown that blood circulation to affected areas is often significantly decreased while the individual is at rest, and a notable decrease in circulation occurs with changes in barometric pressure. During exercise, when circulation should normally increase to muscles and the brain, in fibromyalgia, just the opposite happens, and circulation is decreased considerably. The diaphragm is significantly affected in fibromyalgia to the point that it ceases to function as a major breathing muscle, and accessory muscle of the neck and upper chest take over. The overwork results in tender points on tightness of the neck and chest muscles. In general, the level of muscular activity in fibromyalgia is high even when the body is sitting or reclining. The muscle used for daily activities such as cleaning, cooking, typing, and even socializing are at higher level of activity than the muscles of normal person doing the same task. When the activity is over and the person with fibromyalgia is resting, those same muscles continue to repeat the activity over and over again at a lower intensity so that no outward movement is apparent. This factor combined with increased central pain processing may lower tender point threshold. Okay. Almost there. Okay. 4.7 Special implications for the PTA. Fibromyalgia. PTs and PTAs are often the first to recognize the history and clinical manifestations suggestive of fibromyalgia and then request medical diagnosis and intervention. Rehabilitative therapy is an important component in managing fibromyalgia. Many people with FMS have undergone unnecessary exploratory or corrective surgery and have residual functional limitations. Chronic musculoskeletal conditions that are sources of noxious neural input to the CNS often involve the shoulders and spine. Therapy is helpful first in directing individuals to reach goals of lessening pain and fatigue and eliminating sleep disturbance. Outcomes can be measured in a variety of ways, not only by reduction in tender points, but also by global scores of pain, fatigue, sleep reduction of other distressing symptoms, and improved quality of life. Reduced visits to the physician, reduction or elimination of medications, increased sexual activity, improved work performance, and so on. Many people with FMS have been told that they must learn to live with it. A more positive approach is to suggest working together to learn how to move forward with FMS, respecting limitations but not being controlled by them. The PTA can be very instrumental in guiding the client to understand how to manage these conditions. Strategies for work modifications and applying ergonomic techniques to increase efficiency and decrease pain are important interventions. A chronic pain program may be appropriate. The reader is referred to more specific literature for treatment regimens, self-stabilizing techniques, and therapy protocols for this condition. Modalities in fibromyalgia. Ultrasound can be an effective therapeutic modality for the treatment of pain in people with FMS when combined with connective tissues manipulation and high voltage pulse galvanic stimulation. Also, pulse ultrasound has been shown to be effective in treatment of pain in FMS as combined with therapy with interferential current. There have been some reports on the use of ultrasound as effective therapeutic modality for its thermal effects and for the retirement of myofascial trigger points, often present in people with FMS. Continuous ultrasound is preferable to pulsed ultrasound and should be combined with a complete trigger point protocol. The intensity must be reduced from standard settings to accommodate hypersensitivity in most people with FMS. Specific position, tissue effects, intervention techniques, and treatment parameters are available. Given the proposed mechanisms of muscle pain, hyper responsive myofascial mechanoreceptors, impaired CNS pain inhibitor system. Soft tissue techniques must be applied gently and slowly to increase circulation while avoiding an increase in nociceptors signal transmission with a typical FMS client. Post-treatment discomfort can be avoided by keeping the discomfort level during treatment between 1 and 5 on a self-assessment scale of 1 to 10. Cross friction massage is not advised. Exercise and fibromyalgia. The primary non-pharmacologic modality in the management of FMS is prescriptive exercise. Improvement in both subjective pain and objective measurement has been demonstrated with cardiovascular fitness training or simple flexibility training. Aerobic exercise also contributes by increasing the metabolic rate of lean tissues in those individuals with thyroid component. Resistance exercise contributes to the increase in metabolism by increasing lean tissue mass, which has a higher metabolic rate than fat mass. Well-managed prescriptive exercise regimens improve sleep and result in decrease in pain and fatigue. Gentle stretching exercises performed routinely throughout the day may reduce fatigue. Cardiopulmonary fitness component should be included at whatever level is appropriate for the individual. Sometimes the person's condition is so acute that exercise is not in early stage of therapy. Skipped a sentence. Sometimes a person's condition is so acute that exercise is not tolerated immediately. This is often the reason of the use of modalities in the early stage of therapy. Exercising too soon and committing too much can set the person back considerably, but at the same time, the PTA must keep in mind the long-term goal to increase strength and improve aerobic fitness. Aquatic therapy is ideal ways to begin conditioning, especially for those individuals with FMS who have injuries, are overweight, or sensitive to axial load. Aquatic therapy provides low-level progressive exercises, gradually increasing strength and endurance while improving overall cardiovascular fitness. Ideal pool temperature is 84 degrees to 90 degrees, as with all exercise programs with the population, whether aquatic or other therapy. People with fibromyalgia fatigue quickly and may have low tolerance for exertion. The key is to avoid activating the peripheral sensory mechanisms in order to avoid increasing pain post-exercise. The person with FMS will respond to stimuli that would not ordinarily be perceived as painful, referred to as allodynia. This requires short exercise sessions, possibly even only 3 to 5 minutes at first, according to individuals' tolerance, using the rate of perceived exertion. The client is encouraged to increase exercise duration in small daily increments, sometimes only by seconds or minutes. Reaching a goal of 30 minutes of daily exercise may take weeks to months. Some individuals are able to tolerate only 1 to 2 daily exercise cycles, each lasting only 5 to 10 minutes, but this will produce beneficial effects. All right. The individual with FMS must be taught to set aside the philosophy of no pain, no gain, and to avoid pushing through the pain. In the normal, individual growth hormone is increased with exercise, but this does not happen in the person with FMS. Poor compliance is common when the use of muscle relaxant sedatives or other medications reduce desire to drive to exercise. Symptoms of pain and fatigue increase during exercise, resulting in limited compliance and limited long-term benefits. The PTA can explain that pain may result in part from muscle spasms and reduced blood flow to muscles, both of which can be aided by persistence in managing exercise. People with fibromyalgia are also more vulnerable to overuse symptoms than are people with normal muscle history requiring a slower, longer rehabilitation process. This may not be activity induced as once thought, but rather may occur as a result of sarcolemmal abnormalities. Other resources include the National Fibromyalgia Association. The end.